This podcast is for informational purposes only. It is not intended to provide medical advice. It exists to entertain and to inform. And I wanted to add to that disclaimer a bit because the case we're discussing does involve multiple gunshot wounds to the head in a patient who lived at the end of the 19th century. And we're going to avoid being grotesque or overtly descriptive of the trauma itself, but we do describe the injuries and the physics of what projectiles do to the anatomy as it relates to discoveries in the history of medicine. And with that, I promise that this episode isn't as dark as you might expect on the way through, and it does end on an up note. We'll find some humor here, I promise, but we understand this topic might not be for everyone. So I'm saying this up front, in case you want to go on to the next show. It's totally okay if you do. No hard feelings from us.
Look at cases throughout history. It's just Sarah and Alba, Max and me. You gotta listen, you don't have to read.
Welcome, everyone, to another journey into the Curious Case Vault. This is the accessory medical history show where we will, from time to time, do our best to figure out what happened in a real case from the forgotten passages of medical journal archives, and try to find out what practicing medicine was really like back in the day. These cases involve ordinary, non-famous people and the ordinary, non-famous physicians of the day who treated them. Some things have changed a lot in medicine and others not so much, so we're going to kind of explore that. I'm Dr. Max, and I'll be joined by Dr. Aaron as we play the role of front office to our medical history intern and head coach of this team, who did all the real work for the show, Alba. Aaron, Alba.
Hey.
Woo! Hello, guys. How about those Lions? Just
Hey,
kidding.
man, I'm rooting for you. I'm rooting for you. That would be awesome. It's a feel-good story. I saw a picture of some famous statue in Detroit with like a Hawaii or a Honolulu blue jersey on, and I was like, yeah. Man, go get them.
I don't know
would
that
be
any
fun.
of this is making the show. I just forgot to mention it
What
last
sport
episode.
is that?
Oh
Is
my
that
god.
Football.
hockey? Football? Great.
Yeah, football, the Lions. Personally,
Okay.
I love, if I'm not going to, it's not going to be a team that I'm following. I love an underdog.
There you go.
And
America's team
they
now.
actually, I think they have a good shot, but so I don't know if they're an underdog this year, but generally,
yeah.
I think it's fair to say
Yeah, no, they are
Detroit's an
the underdog of
underdog.
the year.
Oh, right. We're getting close to the Super Bowl. Okay.
Yeah, absolutely. Absolutely. So, Alba, you found and studied a case from very long ago that we're going to try and help figure out what happened. When and where is today's case coming from?
It is coming from Brooklyn, New York in 1888 is when the article was published.
Hey, switched it up. We're no longer doing the UK cases because I found a huge trove of medical journals from all over the place that are like super old. So now we get to travel.
Back when you could actually afford a 2-bedroom flat in Brooklyn.
Yeah, when
Correct.
people
You could buy it for a halfpenny and a couple
Yeah.
of quarters. What is a halfpenny? Do you know? I don't know what a halfpenny is.
Half a penny.
half of a penny.
That's how much things cost back in New York in 1888.
Anyway, let's get to that case. Let's go. We're going to Brooklyn, 1880 something.
We are in Brooklyn, New York in 1888. And this case is a double gunshot wound to the head. So the
Uh-oh.
patient that comes in, he has been shot. He's unconscious, of course, when he comes in, and he's been shot so closely that the muzzle was almost touching his forehead, is how it's described, with two bullets. And the what follows is the clinician essentially trying all methods to find where the bullets have entered, or he can see where they've entered. They entered the left of the median line is what it says. So one to the left side of his forehead and then one to the right side. And it sounds like his frontal sinus has been kind of destroyed. So basically the like section behind his forehead, the bone structure in there sounds like it's been pretty well torn up.
Yeah, I think that's fair from my reading of the case. This, and I will say we should point out to the listener, I think it said so in the disclaimer that I haven't done yet, but that we didn't pick this case because it has an unhappy ending. So I want to put that out there up front. This case was interesting because it stood out with what you just said. ends up in not the worst place. You
It's
know
a
what I
dark
mean?
Yeah.
beginning, though. It's a dark beginning.
So
You
there's
know,
got to be a little something.
I do have, though. I mean, I have vivid memories of, so we had these giant lights in the trauma bay, and there'd be this row of paper tape with, in the middle of the tape, there's a paper clip that's been open, so it makes a V shape attached to that tape. And when we receive gunshot victims, there would just be this line of tape. And finding the holes is actually a huge part of the initial management of gunshot wounds, because entry and exit, if you have an even or an odd number of holes, it's a different situation, and you 100% do want to find them. Now, I mean, less so with a head wound, but
Still
yeah,
curious.
we would always do that. So like when we get the x-rays, you would tape the paper clips onto the patient right at the wounds, and up facing for the front and down facing for the back. So then when you look at the x-ray, you can look at, okay, where's my bullet?
The paper clips are actually making arrows on the
The
x-ray.
paper clips will make an arrow on the x-ray. So then you're like, oh, so you can try to match them up, because depending on where it is, I mean, huge implications for what could have happened. And yeah, I mean, bullets will go into the body and then they will move. They'll either spin or ricochet, or they'll hit internal structures. And again, this is probably why it's a good thing there's a disclaimer, but they will kind of bounce around sometimes. And in rare cases, it's described they'll get into a blood vessel and then travel in the blood vessel. So that's actually been described as well. It's called a bullet embolism. Yeah. Pretty crazy. See, I don't know anything about rashes, but you start talking to me about gunshot wounds.
It's something, unfortunately, especially here in the U.S., we see a fair amount, right? I actually have to wonder, our international listeners, which we have a fair amount, I wonder, outside of things like war scenarios and whatnot, I don't know how much they see, depending on the country and, of course, depending on their laws. But this basically starts out, this is a pretty grim beginning, right? So we've got 2 gunshot wounds to the head.
Had not even occurred to me that finding the entry and exit would be, wow.
So that is common. So we also are going to, somebody is brought in, we're going to try to figure out, okay, where to go in, where to go out. They mentioned that it was close enough that they could see. So if we're not forensic, so emergency medicine docs are not forensic pathologists, but you will get kind of a stippling pattern, or like a little extra pigment or dark discoloration from gunpowder if the muzzle is really close to a gunshot victim. So that's not a great story though.
Wow.
So it was really close. So they would have probably been able to tell that by looking at it, be like, okay, this was really close range.
Yeah, and so it sounds like right around the eyes and forehead, and then the bullet was, not sure how, I guess it does make a difference. The bullet was a .32 caliber revolver, and so that sounds to me like, it's, as someone who knows zero about guns, like a big one, but I actually don't know.
I think the other thing that's kind of interesting about this case is it's actually taking part on a historical backdrop when medicine, as far as gunshot wounds and the treatment of them go, had to evolve pretty rapidly during the 19th century because guns were changing. And so you went from, let's say, Civil War and before, where a lot of guns were basically muzzle loading. So you'd take a lead ball, you'd ram it down the barrel of the gun. Before that, you'd put some gunpowder and you would fire it. And it wasn't as accurate as, because that bullet, or the musket ball, could tumble and spin in different ways, and so they weren't super accurate. They're effective when they hit, but not super accurate. And so during the mid 19th century, especially, rifling of barrels starts to happen, where they can put these grooves in the barrel, and then they started making casings where a bullet goes into a casing and you put it in. And so the bullet spins now, and it, comes out with a different shape. And when it hits, it's, they're coming out at higher velocities. And so this leads to medicine having to really adapt to a lot of this as best as possible. And so this case, actually, kind of interestingly, I didn't realize this when I came across it, but it comes at a time when the treatment of gunshot wounds was trying to rapidly evolve in medicine,
Trying to keep
because
up, it
the
sounds
damage
like.
that was being done was different. And so they were literally almost at the exact same time that this case is going down, there's some cutting edge for the time work that's being done on ballistics to basically find out why these things do the damage that they do. And so I'll talk about when we get there. But
So yeah, as it's not just the bullet that, as y'all kind of mentioned before, it's not just the bullet that caused the damage. The doctor also talks about pieces of the bone that are dislodged from the bullet, and then the pieces of the bone that have gone back into the cerebrum, I guess.
yeah, and basically that's the cerebrum is the main part of the brain, the main substance of the brain,
The brain part,
the brain parts of the brain.
not the stem part.
Correct. Or the
He
cerebellum.
talks a lot about trying to find the course of the bullets of both of them. Ultimately, he's not able to find them.
Mhm.
Wait,
He
how does
says
how does he try to find the course?
So he talks about trephining. I don't know if I'm saying that word right,
Uh-huh.
but
Trephining,
like
yep.
is
Uh-huh.
drilling. That's drilling a hole
Yep,
into
making a
the
hole
skull.
in the skull. Yep.
Uh-huh.
So he's kind of drawing a line. Okay, this is where the bullet entered, and then drawing a line, assuming okay, this is likely where it would be, and then drilling a hole into the skull to try to
Yeah.
find that.
Okay.
Did I
So
understand
the
that
way
right?
that I read
Okay.
that, basically what he was doing is he was looking at where he knew the bullets went in. And then he was trying, when you said drawing, I think my impression was that he was doing a mental line, basically saying,
Okay, yeah,
if the bullet
an
went in-
imaginary line, yeah.
Exactly. And I think he says that.
Yeah.
I had an issue. I had to close the file I had open, but I don't have it in front of me. But he had a line basically where he said, I think it went in here. And he's trying to imagine that if he were looking through the skull, where that line would be. But Aaron pointed out something that is when bullets go in, they don't take a straight path often. And so what he ends up doing, and you were mentioning the trephining, he basically says the hole is in the front. So I'm going to go to the opposite side of the back of the skull, make a hole, and try to figure out where that bullet went. Did you follow how he did that? Because it's kind of bonkers.
I didn't quite get that he had gone to the back of the head for it. I got that, okay, he kind of tried to guess the angle of the gunshot and then just drill a hole where he thought this is likely where it is.
So the part of the clue for me was in the anatomy, because he said, I like imagine a line going through to the occipital bone, and that's the backbone of the skull. So that's how I knew where he was going. So yeah, he does, as you say, he treffins a hole. He makes a hole in the skull. And I should mention too, this is 1888, so we have anesthesia, fortunately, and and everything like that. So that's important. That's good. But he makes a hole in the back of the skull, and then I can't remember how he worded it. He takes a
slender needle was passed into the brain substance, is how he described it.
Yeah, I think a radial pattern. He said from there,
lines radiating from this lateral opening to all portions of the brain. So it sounds like he sticks the needle in there and he just starts fishing around.
That's honestly what I think is going on.
Yeah. I mean, he was systematic about it. Let's give him that.
I just have to say, as someone who just watches, again, I'm no doctor, so I don't know brain stuff, but as someone who's watched movies, why I cannot imagine that seeming like in my mind, if you start mashing up the brain matter, you're done for. If you poke the brain matter, you're done for.
Well, let's just talk about getting the bullet out in general, because this is...
Yeah, we've mentioned it tangentially before on the show, but I don't know how much time we've spent on it otherwise.
Oh, man. You want to rant about this, or should I?
No, you're all worked up. Go for it.
I mean, so every single show I've ever watched, they're like, oh, you know what would be magic? If we dig around this person and find the bullet and pull it out and drop it in a pan and then sew up the outside. That's like how they take care of gunshot wounds all the time, which is not how you take care of gunshot wounds. The bullet itself, the bullet itself, where it is important because you need to know what's injured. But actually, this bullet might be lead. So it actually might be in 1888, it might actually be relevant that you would be leaving a piece of lead inside a person that could poison them long term.
Potentially, yeah.
In modern days, non-lead bullets, like removing the bullet is not paramount. And in fact, most of the time,
depending on where it is.
Depending on where it is, It's potentially harmful, right? So you don't remove the bullet for the sake of removing the bullet now. You
Right.
deal with the damage the bullet has done. And if you can get to the bullet, great. I mean, if people are going to go to surgery for like an abdominal injury or chest injury or whatnot, sure. I mean, I'm sure, I guess I could ask trauma surgeons, like, do you try to get the bullet if it's right there? I'm sure they do. But like where the bullet is has much less import than what it did already.
Mhm.
So like trying to poke a needle into the brain, the only thing you're going to be doing there is making it worse. I mean,
Okay, good. That's what it sounded like.
Part of the reason I think a lot of these movies do this, especially, like, there was a lot of historical precedent. We've done an episode. It never made it yet. Maybe we'll
it's
go
still
back
in our
to
vault.
It's still in our vault.
recorded.
We have an episode
we could
on
re-record
President
it.
Garfield,
Yeah.
who was shot, and essentially, as all his doctors are fishing around to try to get the bullet out, he ends up dying of infection because and who knows?
It
was an infection,
in his body.
hemorrhage.
They poke their fingers in his body to find the bullet.
They're doing
Don't
this
do that.
heroic act of like trying to remove this thing, and it's like he was doing reasonably okay, all things considering, and then he eventually, I believe, he died of infection or hemorrhage or both. I can't remember
All the germs.
Well, it eroded into his.
Either way, it was
pancreatic artery.
So there were physicians who, through history, finally started to change how they approached this, and it came from empiric evidence, just seeing something and going like, maybe we have it wrong. And like one of my favorites that I know off the top of my head, we haven't done a show about him yet. Keep teasing it, we will. But it's John Hunter, who is a famous Scottish surgeon, who serving in the I can't remember exactly which war it was. I think it was one of the Napoleonic Wars.
Probably always the Crimean War, if you can't remember.
Well, that's mid 19th century, I think. Anyway, he's serving in the military at the time, and he comes upon a bunch of soldiers who were shot up on an island. And these soldiers had been left behind. The British forces were sieging the island or whatnot. And so all these guys took gunshot wounds, but they'd been there for like 2-3 weeks, all of them with gunshot wounds. And they were, they had issues, but they were alive. And they were like, yep, I got shot in the leg or I got shot in the arm and I'm still alive. They're just surviving at this point. And he was one of the first surgeons to say, maybe we don't go get the bullets out all the time. These people they're alive. I don't know why we're getting the bullets out. He raised the question. A lot of people thought he was being silly, but he was right in many respects. These people were alive. They were shot. Nobody was fishing bullets out of them, and they did great. They did better than most of the people of the time. So
yeah. So modern injury, right? Like
yeah. Because if it's not like blocking something from going where it needs to go.
That's
correct.
Probably the best summary I've ever heard of that. Exactly. Yep. Right. If there's not an injury to a bone or a vessel, or in some cases a nerve or something like that, or it's not in a critical space, you can leave it, and it's going to be a completely inert.
I got piercings.
Body's going to heal around it.
That's true, man. Yeah. That's true, and it's but I mean, there are definitely times where it's lodged near something where if it could move or shift, it could be a big issue. Yes. There are times when you do have to do it's. I think with any removal of something like that, it's always a risk and benefit kind of analysis. And so it's you see a lot of that though in the movies and history. Like, oh, let's get the bullet out. Like, nope, not always the case. Yeah, and so with this guy coming back to the cases, he's saying, I think the bullet went in this part of the skull at the front and then went through the brain. And then I think I should find it on a straight line in the back. So I'm going to make a little hole and I'm going to use a needle and kind of basically insert and remove it in different areas.
Just starts poking around
to try to poke the bullet. Now,
I mean, he said a slender needle, so that's good.
Let's say, it was a tiny, but let's say he does poke the bullet, which he did not. He did. That's part of what he says. He goes, I don't know, it's in there somewhere. That's probably true.
What was his plan?
Okay. What were you going to do? Are you going to 1888 open up the occipital part of the scalp, the back of the scalp, and then just like go find it? And I don't know what his answer to that question was. I did look up what they generally recommended around these times, so I'll go into that a little bit if you want. But I don't know what his plan was after that.
Well, what was the recommendation?
What was it?
Well,
what would they
I'll
have
tell you
done?
what. Why don't let's go through the case and then I'll summarize
Okay.
it, because here's the other thing. We like to, because usually it's easy, rag on some of our historical compatriots for doing what seems now to be silly, but if you take out all the fishing around with the needle stuff I just talked about, this was pretty well done. And I'll explain afterwards.
Yeah, the closest he got to finding the bullets was he found some bone that had that was stained with the lead of the bullet. So the closest he got was when he was in the front part, the frontal sinuses. He got a piece of bone that had some lead on it. He could not find the bullets through the poking. The old guess and check.
Yep.
And so he closed. All the openings were closed. He, sews up the guy. He put in, which boy howdy, this was fun to look up. Cat gut.
Cat gut. Yeah.
I was like,
heck yeah.
Please tell me that's not what it is, but it is what it is.
It is.
And I saw that it was used for sutures, but it doesn't sound like he used it for sutures. It sounds like he used it for drainage, that he put it in to drain the fluid.
What I think he did, it's not clear from reading it, but I think and I'm trying to think through their process and kind of what a modern physician would be thinking. It's not really described how much facial damage this patient had, but there's got to be some. And so what I think he was using with the cat gut was I'm going to bring together, because he talks about sewing the tissues overlying the bones together. Mm-hmm. So what I think he was doing with these sutures is trying to sew pieces of bone fragment that he thought were still okay near each other, hoping that they would heal, sewing other parts of the soft tissue together to, basically start closing wounds. But the way he described it, I suspect he was also leaving parts open, which is kind of smart, because sometimes you don't want to seal up all the stuff. You want to let the stuff drain. I'm not saying you always want that in the brain necessarily, but he was trying to, I think, keep passages open so that he can close wounds. But if there was going to be infection, which I'm guessing he thought there's a high likelihood here because he's not wrong, then you don't always want to seal the skin everywhere because it might seal an infection. Now, this is probably a very complicated wound, and it's 1888. So this is like one of those areas where I give a lot of grace. I think it's probably the most reasonable approach given what they have. Bring together the parts that seem to come together okay, leave some spaces in case stuff needs to drain out, and maybe try to get some bones in the right position.
Yeah, he says about a dozen strands were passed into the wound through the frontal bone, through the tissues of the covering the frontal bone, and then half a dozen strands were passed down through the frontal sinus. And it specifically says to afford an escape at this point. So yeah, that was what it sounded like.
I'm guessing so, yeah.
Some drain happened. Irrigated the nasal cavity with a mercuric iodide solution. So like I'm guessing that's
I didn't look that up, but I'm guessing it's antiseptic, especially with the iodide. Yeah. I don't know why the mercury's in there, but so basically what he says irrigating, he's washing it out, right? So all these bits that are supposed to be inside your body and now are exposed to the outside and exposed to whatever is on the bullet too. He's washing those out. He's basically trying to say, I want to control the infection in these areas by washing them out. He doesn't have antibiotics. Yep. Can't give antibiotics. They don't exist yet.
And then he stuffs with cotton and antiseptic dressing. So basically he washes it out, dresses it, and he's like, all right, we're going to see what happens.
Yep. Oh, and doesn't the dressing, those iodine, didn't they have iodine in the cotton? I think I remember him saying that.
Oh, yeah. Iodoform cotton and antiseptic
Guess
dressing.
what we still use today?
Oh, really?
We still use iodoform gauze.
Dressings.
Oh, iodoform. You can tell I've never read that word before.
No, it's okay. Yeah.
Iodoform. Okay.
So we still actually,
I didn't know that. That's cool.
Iodine in it's also like one of the big ingredients in betadine, which is like a classic surgical soap or antiseptic solution that we use. It's still used today. So like, this is one of these areas where it's like, actually,
didn't do too bad.
To this point, this makes sense what he's doing. Again,
these are like non-antibiotic forms of and a sepsis, basically, right? So
Yeah.
So the nuttiest thing that I read was after this, the patient's history is entirely uneventful and he never even complained of a headache.
Yeah, I like that.
What?
This is 1888 Brooklyn. This guy is not complaining. He's like,
Oh, yeah.
but he's not complaining, and he's alive.
it's a flesh
He's-
wound.
He survives. That is bonkers.
Yeah, so he's hangs out, gets better for about 3 weeks, and then he leaves the hospital 3 weeks after he
Oh
was
wait, but
admitted.
I think you're overlooking one of my favorite parts of the story.
I'm
What is he
sorry.
doing at 3 weeks?
Oh, he's assisting in the wards of the hospital as a
I
ward
love
orderly,
this.
which I thought I might have been misunderstanding something, but since you brought it up, I'm like, so as he was healing, they were like, "You get to
Yeah.
work, buddy." What?
And probably a nurse is like, "You're good. Why don't you help me out?"
That's, I don't know what the medical reimbursement system was in 1888 in Brooklyn, but it's an interesting, like, hey, you're here, let's have you pull some weight. Now, I don't
He had
know.
to work off his bill.
I don't know
thought
if
the
that's
reason
honestly
he
what it
there
was.
to chill out, like
Yeah,
to
maybe
rest.
he was like, look, man, I would rather be doing, I've got to do something. I'm bored. I think
well,
definitely
Mr.
one thing
Tough
that
Guy.
happens to patients, when you're in a hospital, if you have to be in a hospital for a long period of time, nobody wants to be there. Nobody would blame you for not wanting to be there. And sometimes, whatever we're doing, it requires you to be in bed for long periods of time, or at least that's sort of an implied thing. And so a lot of patients are like, I just want to walk around. Like, let me walk around, because if you're in a
Okay.
normal life, you don't like being just in a bed. And we know that patients just sitting in a bed for long periods of time start to develop problems like, blood clotting, etc. So I don't know how much of this was like, I'm just restless. Like, can I do something? And they're like, yeah, man. Yeah, let's.
Maybe
get to work.
he asked for the job.
That's possible. I'm
It would have been
guessing. I
nice
don't
to
know.
see some more documentation about whether he was like different, or his cognition was changed, or his personality was changed.
The only other thing that they said was different about him, and they're not even sure that it's attributable to this, was that his pupils were different sizes. His left pupil was considerably larger than the right pupil, but they said they weren't quite sure if it was due to the injury or not. And someone later described it as probably a congenital defect, which means from birth. Is that right?
Yeah.
You should know that as a grown up. In this
So
world.
yeah, when I read it,
Mhm.
they describe a guy who comes in with 2 gunshot wounds from, sounds like, close distance, the frontal bone, and then they went whichever trajectory. That's not really clear, but they went into the brain and didn't come out. And he 3 weeks later is helping on the wards. He's not complaining of a headache, because sure, why not?
Fine.
And then there is no description, besides maybe his pupils are a little unequal, that there's any neurologic deficit. And that's incredible.
Yeah, he comes back.
That's
comes
crazy.
back a couple times after he's discharged for some necrosed. I don't know if I'm pronouncing that right, but
Yep.
basically
Mhm,
dead
mhm.
bone that it
Mhm.
didn't it didn't heal, it didn't take, but it
Yeah.
sounds like the body kind of sequestered that part of
Mhm.
dead bone, and then the doctor was able to take out it was, I think, at 2 different times he came back and had to have that removed, the bone, and he was discharging pus, but then
from
Yeah,
skull
after-
wounds, mind you. This might be one of
It's crazy.
This guy has. I was gonna say like this. All right, what my brain told me to say, and then I editorialized, was like, he dodged a bullet, but he didn't. But he proverbially did, because so many things could have gone wrong between this gentleman's injury and then what ended up transpiring, right? So he gets, not only does the trajectory of the bullet suggest that it didn't go out, so it's somewhere in his brain. Two bullets,
Yeah.
and then did massive sounding damage to his frontal bone, at least to an area around his eyes and the bridge of the nose, based on what they were kind of describing. So
then
then
he gets a hole drilled in his skull.
he gets a hole drilled in the back of the skull where they root around with
It was a slender needle, Max.
It was
Let's
a
not
slender needle, but they
overstate
were
it.
still-
slender.
going in and out of brain matter. So they do all this, don't find the bullet, which honestly is probably a good thing. And then he comes back a couple of times, and I think it's like within a 6-month period. If I'm trying to remember the
Yeah,
timeline.
Just a few weeks
top
in
of my head.
between.
Yeah, and then like he comes back later, months later or something. But he comes back with 2 times with wound problems where those frontal bones, because that bullet had gone in and done so much damage to the bones, if you break bones and they lose their blood supply, those bones die. And so a dead bone is also a potential for infection. And he obviously came back once, at least with pus coming out of the wound. And this is a wound that at least is really close to your brain, as far as
Right.
this, we know
He's
here.
so lucky.
He
How did
not only
not?
misses the mechanical damage, he survives. It doesn't sound like he had a brain infection, but he survives an infection on the surface of his skin, right overlying the brain, which is bonkers.
Well, in the bone around the frontal sinus, which is that's.
And the sinuses are known to, they're a place where your nasal cavity is in contact with the outside world, which means it's always in, bacteria
bones
live in
aren't there anymore, right?
Correct.
They're like
Some
the
aren't.
bones that protect your brain from the outside world.
It's like the article said there was a brain laceration.
Yep.
Huh.
And mind you, all the blood vessel structures that are in the deep part of the brain or in other places, which he missed all of those.
So lucky.
And given the circumstance, the fact that he not only survives, but he survives what sounds like normal. Now, they had an expert, whatever that means, according to this article, go back and look at his eyes and say, yeah, he's had that from birth. I can't think, well, if the bullets went in and around some of the nerves that do supply the eye and make your eyes dilate and then constrict, it is certainly possible that some adjacent nerve damage could have interrupted that and maybe given them unequal pupils. But if I remember the description right, they weren't that unequal. And so I kind of wondered if the doc was like, look at that's all that's happened. And it might actually be that the guy just had slightly different pupil sizes. Most people actually do if you really, really look at them. But it's pretty.
Well, there's up to, I forget the percentage. I think it's 2% for aneurysms and 20% for anisocoria. So anisocoria is a term for unequal pupils. And there are a fair number of folks that just walk around with that.
Yeah, one of my friends has that.
Yeah, one of my favorite stories, when I was a resident in the rotation where you're in the neurologic intensive care unit, you always have patients who could have significant neurologic issues. And one of the things you're always looking for in an exam are their pupils equal or not? And, unequal pupils is potentially a catastrophic problem. But when the patient's chatting with you, it probably isn't at that point. I mean, there's reasons you might go investigating it, but I remember having a nurse run up to me panicked that, so there was a patient with unequal pupils. And if you're in a neurointensive care unit, that should get your attention. It got my attention. I went running down to the room as the patient was ordering breakfast, sitting up and doing very well. And I was like,
they're fine.
That's a good start. It's just a really good start. So I immediately okay. So I walk up and one pupil was gigantic and the other pupil was normal. And I was like, did any other doctors come to your room recently? Like, yeah, the eye doctor was here. Oh yeah.
Oh my God.
They gave, and hey, I'm never gonna fault that nurse for being like, hey, I'm on a neurologic intensive care unit.
Yep.
And because these pupils were crazy unequal. But it was kind of a fun story.
I looked back and it just says, I misread it as considerably larger. Reading is fundamental. The left being comparatively larger than the right, but it doesn't say how much.
Yeah. So
could have been some damage there. Maybe could have been, there are respiratory medicines too, that if you get a little bit in your eye will dilate your pupil. So that's pretty common. I mean, if you're wide awake and you have no headache and you've had no trauma, then unequal pupils are not an emergency. But if you're unresponsive and in a coma, then it's a definite emergency. So it all depends.
And you could get if you have one pupil that's larger than the other, and think about, is there an aneurysm, a swelling of a blood vessel in and around kind of the optic nerve area? That's a possibility. So we'll think about it, but I
said no headache, but we should. You're right.
A lot of times those will have headaches, but you just never. You don't.
Yeah, it's a crazy case. The only thing, the way I would put this together is they talked about the frontal sinus. So when your forehead, if you Google a picture of your sinuses, they have this cool. There's always images of these floating clouds above your eyes. So your frontal sinuses are above the eyebrow and they're in the forehead, but not all the way up. So my only thought is the gun was. Maybe the bullet was a little too low. And if it went through both walls of the sinuses, maybe there was enough slowing of the velocity of the bullet that it didn't
Possible.
actually get that far into the brain. And then the sad, well, not sad, true fact. I mean, if people who are longtime listeners will go back to our lobotomy episode, right? I mean, you can be a reasonably functional human walking around. I'm not advocating lobotomy, but you can be a functional human with a fair amount of damage to the front part of your brain, because that controls like executive function and personality and cognition, but not motor function. So this gentleman could have very easily had some significant damage and recovered well because of where it was, if the bullet was slowed down enough, perhaps by going through the sinus. But that's still crazy, and I would not expect that with a modern firearm. It's got to be because it was 1880s.
Well, I was curious when I found this case. I said, geez, I
Yeah.
wonder what would a neurosurgeon of this time, which is
Yeah,
pretty
do?
new for
That's a
neurosurgery,
great
what would
question.
they like? What
Yeah.
would the textbook tell them to do? So I kind of looked into that a little bit, and I mentioned kind of in the beginning that like firearms had changed a lot in this century, and this I found a pretty cool couple of articles. One from the American Academy of Neurosurgery, and then another one was this cool like historical overview. That's kind of where I'm piecing these two together. And so one is kind of the modern, which I'll talk about a little bit, and the other one is like, all right, what did they do? So going back to the history of kind of what was recommended, it was interesting because with early like antiquity and Middle Ages, when like the first firearms ever were invented, we think that it's pretty straightforward how something like a projectile causes damage, but they really didn't know. And there was actually a lot of belief that there was poisonous material on bullets, which is not entirely untrue, I guess, but or that the bullets had like almost literally magical properties because they were, born of this new technology, that they caused damage through like sort of unspecified other means. And so a lot of the antiquity, Middle Ages kind of treatments for these things were like certain ointments, dressings, or they did do trephinations of the skull to try to open it up to let like pus come out when they saw these things. So when you don't have things like antibiotics or understanding of neuroanatomy, I don't know that I'd advocate the putting of ointments on the wounds at all back then. But you can see how they're thinking through it. And so, if there's something in the substance of the bullet, maybe we should treat it in a certain way with these topical agents, etc. And so a lot of the neurosurgery of the time where this patient was affected, the way that it started changing comes from mostly the Crimean and American Civil Wars of the mid-19th century. That's kind of where a lot of the literature started to figure. Yeah, I told you.
Love it.
You nailed it.
In the mid-18th century, a surgeon named George H.B. McLeod, he was a surgeon in the Crimean War, and he did like he wrote this thing about, he observed like 630 plus gunshot wounds. And he was kind of talking about how he was trying to find a way, like, let me just take all these cases that are happening and try to figure out like what the best treatment was. And so, what his recommendations were then? Try to control bleeding, use chloroform for anesthesia. Good one. Sure. Good. Be antiseptic, meaning like try to control infection. Protect the patient from the environment, like don't let him get frostbite, and give him tetanus prophylaxis.
Sounds perfect.
All of that is
It's not bad, right?
bang on.
That's great.
Perfect. So the next thing I was like, all right, so what about all the bullet fishing out? Like, how did that come into play? So he wrote that like, based on this, I don't know if trial is even the right word, just case series, that the primary surgical indications were you had a skull fracture with a great depression, you had skull fragments deep in the brain, or that the edges of the fragments were causing, I think he wrote irritation of the brain, which I liked, or you just can't really make out what's damaged from the external wound. Like you can't use a probe and or forceps and like take out the bullet or get the skull fragments, and you need to open up the skull more to do these things. Those were his primary indications, and there's some partial credit there, I think, right? Like if
totally
there's some reasons to do those things there.
To a neurosurgeon.
Yeah, and then the secondary indications was like, you think, this is funny because I think there's better evidence that this was a better reason to do it, but compressive symptoms or swelling on the brain. Basically, he thought if you thought that there was swelling on the brain, that would be a secondary reason to do a surgery, which is interesting because this will get reversed, I think, really in the modern age. And here's the thing, like he even wrote, he goes, I don't know what to tell you, because whether we do surgery or not, these gunshot wounds to the head that we're seeing in war, they have a really bad survival rate. And so
there's the neurosurgeon I know.
yeah. Well, I mean, it's certainly untrue in that time, right? A lot of this gets accelerated at the turn of the 20th century. And you have a guy named Sir Victor Horsley, who is a pioneering neurosurgeon. And this is sort of where it comes into, he does studies on like, well, how do bullets, how do projectiles do damage? Which again, sounds like, well, yeah, I mean, they go fast and they hit things, but he actually did experimentation on this and he discovered some things that were important here, right? And so he did a bunch of clay models. This is in 1890. This would have been 2 years after this guy's case.
Sweet.
And so
excited about what he's going to find, because
so he takes these different clay model. I don't know exactly how he formed them, but different, he'd take a standard shape, I believe, and then do different degrees of hydration in the clay. So some clay was really moist, some was not, and he would fire bullets into them. And what he basically described is, he's like, yeah, the speed of the bullet matters, and that's not surprising, but he also figured out that they cause cavitation. And that is when the bullet hits the clay, the bullet pushes on the tissue, but it's going so fast that it creates like kind of a vacuum behind it, and the tissue forms a cavity behind it. And that's where most of the damage really happens. And so
it's not just the little hole, it's the like blowout behind it.
Yeah, and as it passes through, it'll cause like waves, cavitation waves and disturbance like throughout. So it'll like all the tissues in a broad pattern will kind of get pushed out and then snap back, and all that trauma kind of spreads. Yeah.
That's physics.
Yeah.
That is definitely physics. And so the other thing he found out, he said that most likely that the way that a bullet ends somebody's life, if it enters the brain, is that it causes swelling. With all that damage, it causes swelling that presses on your brainstem, and then breathing goes. And he said, if we can support people with breathing, we might have a chance here. And he's not wrong that does give a chance. It happens. And he said the second reason probably is that bleeding. And he was right about that too. And when he took all the stuff that he learned, and a lot of this came from World War I, that was where a lot of his research comes from. He said there's probably these 5 factors that really figure into how well somebody's going to do with this. And he said you got to take into account the mechanism of injury, kind of where the bullet hit and what kind of bullet, etc. How well timed your resuscitation of the patient, how well you're supporting their circulation, their blood pressure, etc. Your critical care management of the patient, how well you're supporting their breathing, etc. And the extent of what choosing to do surgery, like how trying to limit that to only cases that are needed, and then treating seizures post-operatively and getting a patient rehab. And those were his foundations of what you should do when this happens. And those are still pretty much the foundations.
Mm-hmm.
Those are kind of the general things that modern neurosurgeons have built off of. And so then I went to the modern and said, okay, well, what do we know? And here's the thing, with all the technology and all the stuff that we have today, 90% of the time, somebody does not survive the wounds that this guy has, right? So that's from the American Academy of Neurosurgery. And then of those folks who do survive, half of them will likely have seizure disorders after. So all of that adds up. And what modern neurosurgery could add to this question is, okay, that first surgeon we talked about in this case was very, very fixated on where the bullet went, right? Or where those 2 bullets went. And it turns out that's maybe not surprising, but it is very important, because if the trajectory is through the middle of the brain, where we have some of our most important vascular and other structures for general operation, if it goes through there and it goes downward, especially towards like the back of the brain, etc., you're going to unfortunately have more problems. And if it, however, is confined to one area of the brain, one lobe or one side, and stay more superficial, you may not have many problems at all. And there's a lot of gray area in between all of that. But today, the mainstays are controlling bleeding. If there's too much pressure because that bullet has caused bleeding in the brain, they can open the skull, they can let the pressure out. You try to prevent infection, you update their tetanus, you do all those things that the other surgeon said from the annals, and you give a better shot today than you did in 1888. But I bring this up just to try to stress how incredible it is that this guy survived. And yeah, going back, that initial surgeon, honestly, the only thing I would say is, he was trying to probe around. That was a problem, but everything else was right. Everything else was right. He gave that guy the best shot of surviving, given the tools, given the understanding he had. And
he did. He survived.
And he did. He absolutely succeeded. And so,
without so much as a headache.
Yeah, there is a saying that certain teachers would deploy at certain times throughout training where they would be like, don't just do something, stand there. And obviously there's a lot of nuance to that statement, because many times you have to do a lot of things right away. But in certain, like, you got to consider, right? There's the flip side of that coin. Sometimes you're just going to make things worse, and you got to figure out which time is which. But there are definitely times where we're going to make things worse, not better. And in this case, the fact that he kind of was like, didn't find it, abort mission, and then just kind of sew some stuff up and let the guy recover and be on the wards is what probably saved him, because he didn't monkey around too much.
Absolutely. In modern time too, we have antibiotics, which would be given because of course. And then we have imaging. We can do a CAT scan to see where the bullet is, and would we do anything about it?
Is it worth fishing it out, or is it better?
Which most of the time is no. It's left alone. It's what's been done has been done, and it's much more likely that you're going to cause problems by cutting it free. And so I think the interesting things about this case was kind of like a reappreciation of how incredible the brain tissue is to withstand these things.
Yes.
At the same time that it's very susceptible to these injuries. So like in certain cases, and I think that the guy who wrote this case up, the one that you read, Alba, was like, he's just like, this, I just bring this up to say it's incredible not only that he lived, but that this tells us that the brain is very resilient in the right circumstance, which I think is fairly true to say.
Yeah, I would say as a kid, again, gosh darn movies, I had the impression that like you don't even poke the brain. If you poke the brain, that's it.
That's a good idea. Don't poke the brain.
I'm not poking my brain.
Don't poke the brain. That's a good rule. Good life rule.
But like I had the impression that like the brain cannot be touched or damaged in any way, or it's lights out. And then, in high school, I learned about Phineas Gage and the frontal lobe, where he had that railroad spike that went clean through his forehead and survived that. And so it's like, so reading this, it was just incredible to me that there could be so much damaged in there, like so much trauma, even the needle poking around at all different places. And it's like, nope, it's really, I think this is my own limited knowledge of like, brain anatomy, but how resilient it is. Yeah, just how resilient it is and how different it is in different parts.
Getting better at the brain, but it is still so complex. And I think there's still so much we don't completely understand about how it recovers from damage and remodels and heals or doesn't and so on. I mean, it's pretty, it's pretty fascinating organ.
Well, I was going to ask you, Alba, like with all of that, because you are, as you know, the show's most bestest medical history intern ever. What was your favorite thing about the case? Was that the resilience? Was that the thing?
Yeah, I would say my favorite thing about it is seeing ourselves in the middle of history, because we have come so far in understanding these things, and yet also we still don't know everything, and there are still some mysteries. I like the feeling of being in the middle of history and not thinking that we have everything figured out, because we don't.
That is a very inspiring way to put it. Makes you want to like go back to work. I'm excited. No, you're right. Things are, changing day by day, right? Almost, it feels like.
We don't know yet too. It's at once exciting and terrifying in many ways, but I like your positive spin on it. I agree with you. So with that, we hope everyone enjoyed this episode. And if you did, please do let us know. shoot us a message through our website, www.horrorhistorianspod.com, or through our social media pages, and tell us if you enjoyed this one. If so, we definitely continue doing them. So far, we've had a lot of folks say they enjoyed them, so we'll keep it going. Feel free to join us for our regularly scheduled Horror Historians podcast episode, releasing every other week. And if you want to find us on social media, check out our link tree and the show notes here, or at Horror Historians Pod on Threads, and Instagram, and Facebook. Give us a follow, help us grow our community of medical history aficionados, and if you have time, go and give us a nice 5-star review on Spotify, iTunes, or whatever place you get your podcasts. Until next time, the Horror Historians are signing out. AMA.